Hello, my name's Alicia and I am part of the DASH team. Thank you for listening to our site induction visit presentation for DAShED. We aim to go over a bit of the background, the aims of the study and the study design before finishing with some endpoints. If you have any questions after the video, our contact details are on the thank you slides at the end, and thanks very much for listening. Okay, so what is acute aortic syndrome? So acute aortic syndrome, or AAS, is a group of life-threatening conditions that presents with a similar clinical picture. Exactly what conditions are considered under the umbrella of AAS can vary from publication to publication, but for the sake of this research project, we are considering AAS to include three main conditions of aortic dissection, aortic intramural hematoma, and penetrating aortic ulcer. AAS affects approximately 4,000 people each year in the UK. The most common presentation of this syndrome is chest pain, making up 80% of presentations, although back pain and abdominal pain are also common presenting symptoms of AAS. The presenting symptoms can be caused by a considerably large group of differentials, of which some are significantly more common than AAS. Chest, back and abdominal pain account for 2 million attendances to ED per year in the UK. This creates a significant diagnostic challenge. Prognosis of untreated AAS is poor and mortality increases by 2% with every hour of delay of treatment. The misdiagnosis rate during patients' initial emergency department presentations is estimated to be between 1 to 3% to 1 to 7% in literature. This inevitably leads to worse outcomes. Currently, CT angiography is favoured in the emergency department for the diagnosis of AAS. It has a high sensitivity and is widely available. However, due to the clinical picture of AAS being similar to many other conditions, CTA are over-requested, leading to a diagnostic yield of around 2 to 3%. The overuse of CTA does not come without consequences. It has a high significant cost and resource implications for health boards, as well as avoidable ionizing radiation exposure and angst for patients. Chest x-rays, D-dimers, and clinical decision aid tools are some things that clinicians use to help decide whether a CTA is indicated or not. So we're looking at 4 clinical decision-making scoring systems that are currently available or have been proposed in literature. These are the ADDRS score, the Canadian Clinical Practice Guideline Clinical Decision Aid, the AORTAS score, or the Sheffield score. Each of these use key information from the patient's presenting complaint, the past medical history, examination, and plus or minus investigations done to give a score which can then be used to justify ordering a CTA or not. The study aims to collect data on patients presenting with possible AAS to begin to evaluate the effectiveness of different diagnostic strategies and how they impact the clinician's decision to use CTA scans. This will enable us to inform future research and guidelines and ultimately improve diagnosis for this patient group. It is a waived consent study with recruitment based in the ED. While sites are able to recruit for 4 weeks, we realise that this is a big undertaking, especially given the high anticipated volume of patients that will meet the inclusion criteria and the target of greater than 5,000 patients across multiple sites. Ideally, we would prefer as complete coverage as possible of all patients for a shorter period of time rather than a convenience group over 4 weeks. However, how sites recruit will depend on what works best locally. A prospective and retrospective data collection should help maximise data collection, as there is only a small amount of information that is required to be collected prospectively. This includes patient time and date of attendance and clinicians' likelihood of aortic dissection. All other data could be collected retrospectively if required. Okay, so our criteria. So inclusion criteria is any patient that presents to the emergency department with any symptoms of acute aortic syndrome. So symptoms of AAS are defined as new onset chest, back or abdominal pain, syncope, or symptoms related to malperfusion. The clinician does not need to suspect acute aortic syndrome to enroll the patient. even if they have a suspicion of another diagnosis, if they have any of the symptoms of above, they should be included in the study. Exclusion criteria is simply that patients present to ED with no symptoms of AAS as described above. So our primary objective for this trial is to establish data characteristics of the 4 clinical decision tools that we chatted about earlier in patients presenting to the emergency department with any symptoms that could potentially be caused by AAS. Our secondary objectives are as follow. This study is a first phase of 3 which aims to describe the characteristics of ED attendances with possible AAS to determine the service implications of using different diagnostic strategies and to hopefully inform future research. Sites will have different setups and access to resources, so may choose to focus on different screening strategies. For example, where sites are still using paper notes, it may be helpful for reception staff and triage teams to place a case report form in the patient's notes for the treating clinician to fill out when they assess their patient. Good promotion within ED is encouraged with recruitment campaigns, prizes for good involvement, and appointment of local champions. You may think about mobilising a team of helpers, for example, medical students, or utilising turn networks and setting up a rota to have someone working on the DASH project each day. We'll shortly go through some slides which show you what the eCRF looks like, but in summary, it will contain questions about the patient's demographics, information from the history taking and examination, any relevant imaging, and what the suspected diagnosis from the clinician is. Ideally, sites will have some capacity in a research team to be able to do some retrospective screening and data collection. This would really help to reduce the number of potential patients missed and allow for more comprehensive data. This may involve setting up a business objective report using coding from the ED discharge or accessing radiology ordering EPRs to identify all patients undergoing CTA. However, there are some sections on the ECF that require some non-routinely collected data, which is not likely to be found in the electronic patient records or part of the clinician's routine assessment. For example, the clinician's suspicion of AAS is not likely to be routinely added into the EPR. Ideally, the local research team collecting data retrospectively will be able to approach the treating clinician at the earliest opportunity to discuss the non-routinely collected data that's needed. As mentioned previously, we will be doing a waived consent strategy. No personal information will be collected on the REDCap database, so data will remain fully anonymised. All access to data before anonymisation will be undertaken by the direct care team. Information for withdrawing from the study is available on the patient information sheets. When recruiting participants to the study or completing the electronic CRF, the local study team will add the participant study ID and hospital number to a secure database, which is an Excel tracker, to enable 30-day follow-up. Once 30-day follow-up has been completed for that patient, their identifiable information on the Excel database will be removed because it's no longer required. And these are the 3 kind of follow-up questions that we'll be looking at.
Hi, my name is Nikki Freeman and I'm the trial manager for DAShED. So I'll first of all just summarise what Alicia has discussed and what the study flow might look like. So if you can follow this chart from the top, a patient will present to the ED. If they fit the inclusion criteria, there's several options of how this patient's details may be entered onto the database. So option 1, the patient's clinician will fill in the REDCap using the QR code. Option 2 is that the research team can retrospectively identify and enter data through whatever screening methods they've set up in the ED. Or option 3, the research team will search radiology EPRs for CTA requests. So if it is the clinician entering data, they can theoretically complete the baseline data on REDCap either at the time or retrospectively, and I'll go into that in a little more detail in the database training. However, the research team will complete the 30-day follow-up obviously at a later point. So if the research team identifies and enters data for the patient, they will need to identify the treating clinician to fill in section B of the database. So the endpoints are as follows. And further endpoints are listed here. You can go back and read these in your own time. So I'll now take you through some of the database training, and the database that we're using is REDCap. Some of you may be familiar with that, and it may be accessed using a QR code. So importantly, no identifiable information will be inputted onto REDCap at any point. The QR code on this slide will take you to the training database, which would be useful to familiarise yourself with the database. So this QR code is for the live database. Need to think about making the QR code as accessible as possible, for example with posters in the emergency department if allowed, or added to the bottom of computer screens, or potentially printed out to stick on the back of an ID badge. And you do not require a login for the database if you're a clinician inputting data, but you will require a login if you're part of the study team and you're accessing other participants' entries. So the first section on the database that you'll come to asks for you to confirm that the patient meets the study inclusion criteria, and if you've answered yes, then the next section, which is section A, will ask you for the name of the recruiting emergency department clinician, the date and time of their ED attendance, and the patient's initials. Again, importantly, no identifiable patient details are collected here. However, there is enough information to be able to confirm the correct patient when returning to the ECRF to fill out any retrospective data. So section B asks for the clinician's suspicion of AAS, and sections A and B are really the minimum sections that would need to be filled in prospectively by the clinician. So section C requires details about the history of the presenting episode, and section D relates to any relevant past medical history. Section E relates to any relevant physical examination findings. So section F pertains to investigations, and when the clinician has filled in as much of the data as they're able to, they can click Save and Return Later, shown by the red arrow. Other sections that will need to be filled in include section G, which is completed by the study team at 30 days, and this is where the AAS is confirmed and the final hospital discharge diagnosis. So if the clinician has clicked Save and Return Later, they will be asked to input their email address, which will generate a survey link, and this will allow the clinician to return to REDCap if they get the chance to fill in any more details, such as the investigations or discharge diagnosis. So if the clinician loses this link, then they can still find their patient on REDCap by looking for treating clinician, patient initials, and admission time. So as explained already, all clinicians will be able to input data into the REDCap database using the QR code. However, this is just for their own patients. Only the local study team who have received login details will be able to access the dashboard as shown here, and other patient CRFs for retrospective data entry. So welcome to the SOP training for the DASH trial. This training video will focus on the sponsor SOPs that are relevant to this study. So the sponsor for the DASH study is Accord, and all Accord training materials, including SOPs, can be found on their website if you need to access them. So the PI is responsible for the conduct of the study at a specific site. A localized copy of the study delegation log can be found on the DAShED website, and the PI is responsible for all study tasks, so only needs to complete the PI section at the top. Please return a completed copy to the DAShED email address. So a localized copy of the training log can also be found on the DAShED website. Please return a completed copy to the DAShED email address. The PI is responsible for ensuring that the research team are fully informed of the protocol and study-specific procedures. So it's important to report your recruits on the CPMS database each month. If you're not sure how to do this, please contact your local R&D team or email the DASH study team. So for the DASH study, where possible, study data should be recorded directly onto the ECRF. So we will be adopting a waived consent strategy where no consent is taken. Patient information sheets, will be available upon request, and details on withdrawing can be found here. Access to data before it's anonymised will be undertaken by the direct care team. So if research misconduct is suspected at any point, you should contact Accord, whose email is qa@accord.scot, and they will investigate and escalate as required. So in terms of study closure, closeout visits will be carried out by the DAShED team, and they will be done remotely. So if you'd like any further information about the DASH study, or if you have any further queries, please contact the DASH study Gmail. Thank you very much for listening, and good luck.